Hello there and welcome back. This is part 2 of soft tissue calcifications. We'll continue with Phleboliths, then we'll have Rhinoliths and antroliths, Stylohyoid ligament ossifications, Calcinosis cutis, Myositis Ossificans, and then we'll end with some cases to see how much you've learned. So Phleboliths, these are calcifications that come from intravascular thrombi in the head and neck. In about 95% of cases, these are associated with a venous malformation, or sometimes we'll refer to that as a hemangioma. These may be seen in adults, although hemangiomas tend to occur younger. These may be residual from a regressed venous malformation. Typically occur with venous. All right, and the appearance of these is going to be round and laminar, donut in shape. To me, they kind of look like a micrograph of a red blood cell. You know how it's kind of biconcave in shape, has a very specific appearance. Phleboliths kind of look like that. Differential diagnosis, if these happen to be in the same location as a Stylohyoid, it might be tough to distinguish, but usually there are multiple of these. And Phleboliths are clustered more randomly. So it is really important to identify these because they need a referral, they need further imaging to identify a possible venous malformation. And here are some examples. Here we have an occlusal radiograph. You see how they almost look donut shaped? Or they almost look, I like to call them like red blood cell shaped, where it's not quite clear in the middle, but it's more dense around the periphery. Scattered, different sizes. All these are typical of your Phleboliths. All right, let's get to Rhinoliths and antroliths. And this is one where location tells you everything. So if you see mineralization inside the nasal cavity, it's a rhinolith. If you see mineralization inside a sinus, it's an antrolith. So it typically develops around a nidus. That could be a foreign body, especially in the nasal cavity in children or drug smugglers. Hopefully you don't have a child drug smuggler. They're really susceptible to it. Or more commonly, you're going to see this just in the sinus around inspissated mucus, meaning mucus that's kind of retained there and dried out. Typically, these are going to be asymptomatic. In rare cases, it may produce pain and congestion. The periphery and shape are going to vary. Typically, we see these as more heterogeneous, kind of that irregular shape, but it may be laminar in appearance. And your differential is going to be osteoma. Osteoma is typically attached to the sinus or the nasal cavity wall and looks more smooth and well-defined, whereas rhinoliths and antroliths are usually separated by a bit of soft tissue or some mucus separating it from the sinus wall. Here's some examples. This is kind of looks like an oblique view, so hopefully you can appreciate you're seeing into the nasal cavity here. Here we have the AP, cephalometric projection, and now you can definitely tell, you can localize between the two shots, radiographs, that this is within the nasal cavity. How do we know it's not an osteoma? Well, between these two different angles, you can see that it's not attached to a wall. It's unattached to bone, and so that's an antrolith. An osteoma would be attached to the wall and continuous with the cortical bone. All right, this one's going to be somewhat rare, metastatic calcification. This relates to genuinely elevated serum calcium or phosphate levels. So I mentioned this, but hyperparathyroidism or hypercalcemia of malignancy. Something systemic is driving mineral out of solution and into tissue. The reason to know it exists is that when calcification is widespread, bilateral or symmetric, it doesn't fit any of these local patterns we've just covered. That's your cue to think about, is it serum calcium or phosphate and something systemic going on? And now we're going to cross the line into heterotopic ossifications. Everything here forward is organized bone, forming where bone really doesn't belong. Most common one here, ossification of the stylohyoid ligament. That's a ligament that runs from the styloid process to the lesser horn of the hyoid bone. Calcified is more commonly at the proximal end, which means the superior end, closer to the styloid process, but it can ossify anywhere along that ligament. You see this is really common, about 1 of 5 people. Almost always this is asymptomatic. Every year I'll get probably a dozen or more questions saying, hey, I think this patient has Eagle syndrome because we see this ossified stylohyoid ligament. Of course, I get a lot more than that if they reported everyone to me, but it's really rare to actually have symptoms from this, but it can happen. So that calcification, if the patient turns their head, it may impinge on the cranial nerve, the vagus nerve typically, or the carotid artery. Typically it's pain somewhere in that around that area, but if it creates pressure on the vagus nerve, that can cause lightheadedness or other symptoms. What it's going to look like is a long, thin, radiopaque process. Can look a lot like bone. Sometimes it even forms these pseudo-articulations where it looks like finger bones. We'll see some of those. Here's an example, probably the thickest stylohyoid calcification I've ever seen. This one's maybe a little more typical, but very discrete. It's very calcified, starting to form that pseudo-articulation, that pseudo-joint. And so these are pretty intense examples, but you'll see, smaller calcifications, maybe scattered throughout that ligament, but anywhere along that path, it's usually smooth and well-defined. That's your stylohyoid ligament ossification. And unless they have symptoms, I'm not going to diagnose Eagle syndrome. All right, Calcinosis cutis, also called osteoma cutis. This is just ossification inside the skin or the subcutaneous tissues. About 85% of the cases are secondary to a long duration of acne, and some texts reserve the term osteoma cutis for those specific cases. But this is commonly going to occur in the cheek or the lips. Just think of small, faint, smoothly outlined radiopacities. A student once asked me, and it hadn't occurred to me before, how do you differentiate these from Phleboliths? Well, these are actually a lot smaller than Phleboliths. You won't see it unless you're looking at an intraoral radiograph that shows the soft tissues really well, so in edentulous areas. Whereas the Phleboliths, they're larger, more scattered. They vary in size, but those are typically large enough you can pick up on a panoramic radiograph. All right, Myositis Ossificans. This is just fibrous tissue and heterotopic bone formation within the interstitial tissue of muscle. So there's two different forms. Localized is the more common one. It results from trauma or heavy muscle strain. An example I've seen of this is damage to the pterygoid muscle following inferior alveolar nerve injection. You may see this in the muscles of mastication. What it's going to appear like is radiopaque lines, radiopacities that kind of have these striating lines that follow the lines of the muscle tissue. And then progressive is a rare hereditary disease with spontaneous progressive bone formation within the muscle. Common in the neck and upper back. Patients are going to get that soft tissue swelling, stiffness. It's going to limit their motion. It can be really debilitating, and in advanced cases can lead to death from respiratory decline. So this is a serious disease. Fortunately, it's somewhat rare. Here's some examples. First glance at this, it just looks like a smooth bordered, well-defined radiopacity, but it doesn't really follow any of those other soft tissue opacities that we've talked about. But think about what's right here. What anatomical structure, what muscle connects to the coronoid process? That's Myositis Ossificans of the temporalis muscle. And this was a case where it arose after several attempts at a nerve block. The patient was then left unable to open. And so that's worth considering for a second. This is an iatrogenic complication of a routine procedure. And here's some CT images, axial and coronal, showing similar thing. Now we can really localize where it's at, and you can appreciate this is the muscle of mastication. This is following the striations of the temporalis muscle. All right, and I really like this diagram from our textbook because it kind of shows all those things we just talked about and the common locations. What's up here that looks like red blood cells or donuts in some cases? Well, these are Phleboliths. And why is that such a common location? Remember, you have your pterygoid venous plexus there, which is a dense network of veins inside the infratemporal fossa. And so not terribly uncommon to get a venous malformation there. And then what do we have here? Where is it? Location is everything, right? Inside the sinus, that's an antrolith. What about this one? Kind of crossing right behind the angle of the mandible. It's nice and smoothly bordered. That's our ossified stylohyoid ligament. What's this pink trying to depict, or purplish? Irregular, ill-defined. Compared to this side, how they drew it, I like it. Nice and smooth on that side. That's your thyroid cartilage and tritichial cartilage, whereas that is representing our calcified atheromatous plaque. What about these scattered round calcifications? Right over the ramus of the mandible, sometimes anterior, sometimes posterior, but usually around the level of teeth. Those are going to be your tonsilloliths, and one of the more common ones that you'll see. And then we have two here in the submandibular regions. The one they drew more smooth and rounded, that's your Stylohyoid. And then the other one that looks more irregular, and that's our cauliflower-shaped one, that's our calcified lymph nodes. They also drew another red one here because what tracks along the floor of the mouth? The Wharton's duct, the salivary gland duct from the submandibular Stylohyoid. And so that's a common location for Stylohyoids. And they drew the fusiform, the kind of oval or football shape there. And so this is a good image to memorize. Think of where these are, think of how they look. And these are kind of the main calcifications that you're going to see as a dentist. And so with that in mind, what do you think we're seeing here? I'll give you a couple hints. They are in line, but not the location of the salivary gland duct. This is roughly the location of the submandibular gland. But if you had salivary stones following a line, it should go forward, right? This goes back. And up that chain, this is a chain of the lymph node. And so these are just lymph node calcifications. All right, what about in these cases? Let's look at this one first. This is in the submandibular region, just below the body of the mandible in the posterior. And so you should think primarily two things, Stylohyoid or lymph node calcification. Let's go back to this one. See how these were more cauliflower shaped, a little more irregular? And then this one is more smooth, well-defined, a little bit layered, almost like our Shrek, but it's not osteomyelitis. This is our typical Stylohyoid. All right, what about right here? This location kind of anterior to the ramus, you might be thinking tonsilloliths, but this is kind of following a line extending forward from the parotid salivary gland. And so this also is a Stylohyoid. What about this one? Floor of mouth, kind of occlusal, That's also a common location for a Stylohyoid. It is well defined and smooth, a little bit heterogeneous inside, but that's okay for a Stylohyoid. So all three of these are Stylohyoid examples. If I gave you the hints, that probably would have helped. Laminated, location, an occlusal film, especially in this one, would really differentiate it. You could see that it's not attached to bone, so it's not an osteoma, not just a dense bone island, but it's something actually in the soft tissues, and that helps you tell that this is a Stylohyoid. All right, this one, hopefully it's easy if you know your anatomy. It looks like someone just outlined a certain portion of anatomy. So it looks just like that anatomical structure, but it's further inferior than the hyoid bone. You can really appreciate it in this 3D view. If you weren't sure in this one, you're looking in the axial slice. We're now below the hyoid bone, and it's really following what? The thyroid cartilage. So this is just thyroid cartilage calcification. All right, here's one where location is everything. That's your hint. Where are we seeing? This is an axial slice. This is the nasal cavity with the concha, the turbinate. This patient does look like they've got some sinus disease because this is the maxillary sinus and the walls are very thickened and sclerotic. And so this calcification is within the sinus. Here in the more coronal view, you can appreciate there's a fluid level, but there's this nidus of calcification inside, so there's an antrolith going on. I like this one, mainly because the striating pattern kind of tells you everything. First glance, you may say, oh, okay, we talked about sun ray appearance, that's osteosarcoma. But if they don't have a huge tumor on the outside of their head, which for an osteosarcoma being this big, you'd probably see that. And they do have a problem with function likely. This is following striations of the temporalis muscle. And then here we can see in the axial slice as well, it's right within, in this case, the lateral pterygoid muscle. But we said this frequently occurs in muscles of mastication, whether the temporalis or one of the pterygoids. And so that's your hint. It's following the distribution of those muscles. And so this is what? This is Myositis Ossificans. All right, what type of calcification is indicated by the arrows? Well, what artery goes here? The facial artery climbs up. This looks like those rail tracks or tram track because it's just outlining with calcification. And so this is our Monkenberg's medial arteriosclerosis. Rather than what's more common is you're going to see that atheromatous plaque that typically accumulates in the carotid artery. What's this one here? Is this arterial or is this a ligament? Give you a multiple choice there. And this just follows the track of the stylohyoid ligament as it extends down from the styloid process. And you can see, as we said, it typically ossifies more from the top, but it can ossify anywhere along that chain. Here's their pseudo-articulation. And so that's just a stylohyoid ligament ossification. All right, first of all, where's the calcification? I was looking up here. There's a little bit of calcification there, but it looks like it's related to this tooth. And then there's the big obvious one in the submandibular region. What does it look like? Does it look more like lymph node or Stylohyoid? Nice and smooth and well-defined, somewhat laminated with that little bit heterogeneous appearance. This is a submandibular Stylohyoid. And now that we've been through these, this was a case from Dental Town, which is a dental forum. And you'll have dentists occasionally ask questions, which if you're familiar with this lecture, you could jump in right away, sound really smart and say, oh, that looks like what? Submandibular Stylohyoid. So there you go. I feel like this question is something like, what color was George Washington's white horse? What's this calcification within the sinus? Well, location tells you everything. An antrolith. Probably just dystrophic calcifications of inspissated mucus. You see they got some mucosal thickening, maybe some mucus in there. And it's not uncommon to develop calcifications like that. All right, that felt like a lot. That took a lot longer than I thought it was going to be. And so I identify with this, if you do as well. I'm through learning today. And one last Calvin and Hobbes here. As a father of 5, this kind of hit me in the feels. But we'll end on that. So just as a recap, you don't have to memorize that whole list of things, but hopefully you can recognize based mainly on location, right? It tells you what structures are even candidates. Then the shape and arrangement separates ducts from vessels, from nodes and muscles. Internal pattern, specifically lamination, points you towards Stylohyoids or Phleboliths. Symptoms, which for practical purposes means mealtime and pain and swelling, essentially isolate the Stylohyoid. So 2 of these carry real consequences, the carotid atheroma and Monkenberg's calcification. They need to be referred to a physician. Then a Phlebolith as well means a possible venous malformation, and so that probably requires a follow-up with their physician as well. So everything else in the video is basically an incidental finding, and just describe it as accurately as you can. Come up with that differential diagnosis. You'll probably be able to recognize what most of these calcifications are. But that does it for today. We'll see you on the next one. Thanks.